Hi everyone, my name is Scanlon and I'm a fourth year physiotherapy student at the University of Limerick. Today I'm going to talk about some key points on the statistical analysis I carried out assessing the predictive validity of the clinical frailty scale in the emergency department at the University Hospital Limerick. There has been a rapid increase in the number attending emergency departments in recent years, which has become a global health and patient safety issue. Population ageing has led to a greater proportion of older adults living longer lives and therefore a greater proportion attending the emergency department, which has been a contributing factor to overcrowding in recent years. Older adults are more likely to be frail, and frail older adults are more likely to have an adverse outcome and are more frequent users of the emergency department. There are tools that can be used in the emergency department for quick identification of frailty, including the CFS or clinical frailty scale. Frailty is a key concept in geriatric care, becoming a common component of adult aging and development. The clinical frailty scale is a 9-point, easy to use, multidimensional assessment that measures frailty based on clinical judgment. Those who score 1 to 4 are considered not frail, and those who score 5 to 8 are frail. There has been extensive research done, and there is evidence to show that identifying frailty can predict the incidence of a range of different outcomes in different clinical settings. However, there is no general consensus on the preferred method of use of frailty screening. No study to date has looked at the predictive validity of the CFS, looking at our particular outcomes in an ED in Ireland. We set out to determine the characteristics of those aged 65 or greater who attended the emergency department, and if there were differences between those considered frail and not frail using the CFS. We also wanted to assess the incidence of the outcomes mentioned previously, along with determining sensitivity and specificity of the scale and the risk ratio to determine if those who were frail were at increased risk of experiencing adverse outcomes. The outcomes we looked at 30 days included hospitalisation, functional decline, return to the emergency department, nursing home admission, and mortality. This is a prospective cohort study set in the emergency department of the University Hospital Limerick, which is an acute hospital in the Midwest region of Ireland. Data was collected from December 2018 to March 2019, Monday to Friday between 8 to 5, on all eligible participants aged 65 or greater. Baseline characteristics and demographics were obtained from medical charts. Members of the medical team carried out the CFS within 48 hours of arrival to the emergency department. Functional status was obtained using the Bartle Index, and a quality of life assessment known as PSQ18 was carried out. Outcomes at 30 days were obtained through telephone interviews by a research nurse, who were blinded to the frailty status of the patients. Risk ratio, along with sensitivity and specificity, was calculated for each outcome using 2x2 contingency tables. For the most part, our findings are in line with the existing literature, and that frail older adults have different baseline characteristics to those considered not frail, and are more likely to experience adverse outcomes following an emergency department visit. The CFS has also shown good predictability, good sensitivity, and good specificity. Firstly, the study shows that of all older adults aged greater than or equal to 65 who attend the ED, they are more likely to be female, to live with a family member, be triaged through using the Manchester triage system, and the mean age being 79 years plus or minus a standard deviation of 7.1 years. By getting p-values, we found statistically significant differences between those who were frail and not frail, and that those who were frail were more likely to be older, have a lower functional status, and have a longer waiting time in the emergency department. For all outcomes, those who were frail were more likely to experience adverse outcomes, and the figures are as follows. For functional decline, ED revisit, hospitalisation, nursing home admission, and mortality. Finally, the CFS displayed good predictive accuracy and that older adults who were considered frail had a higher risk ratio for all outcomes versus those who were not frail. The CFS also displayed good sensitivity and specificity ranging from 52 to 72 and 0 to 72 respectively. This highlights good accuracy in correctly identifying those who were frail and those who were not frail. Previous studies reflect our results in that baseline characteristics differ with those who are frail and not frail, with those frail more likely to be older, female, have reduced functional status, and previous history of falls. A retrospective study by Wallace that had a much larger sample size of about 7,000 participants similarly found the CFS to have good predictive validity regarding mortality with an odds ratio of 1.6, with our risk ratio being 3.56. Similarly, Basic and Shanley have shown the CFS being good at predicting nursing home admission with an odds ratio of 1.6, and Sferis et al. Showed good predictive value regarding functional decline. However, the follow-up was at 3 months rather than 30 days. Identification of frailty using different screening tools such as the clinical frailty scale can be seen as a risk stratification paradigm in which older adults at increased risk can be identified. This identification can be used to aid clinicians in targeting interventions both in the ED and when discharged home for those who are frail and to develop better short and long-term strategies to avoid the incidence of adverse outcomes, leading to a reduction in the burden on the healthcare system. There is need for better integration of care between acute and community care to reduce the burden on healthcare systems, emergency departments, and to improve the standard of care, patient satisfaction, and promote healthy ageing. Identifying frailty helps clinicians decide who would benefit from the comprehensive geriatric assessment, which is more time consuming but can help determine patients' abilities and if interventions are required. It can help triage available resources to those who are at high risk of experiencing adverse outcomes and in most need for interventions. There are many different policies, guidelines, and initiatives, such as the Integrated Care Programme for Older People and Scanlon to Care, that reiterate the importance of coordinating and integrating care with good transferring of care from acute to community care to ensure more long-term care and follow-up of the patient following an ED visit, recommending a patient-centred approach offering support to live a healthy life in the community and avoid adverse outcomes. A study by Hughes in 2019 emphasised the importance of targeting interventions on patient outcomes, which included case management, discharge planning, medication management, and continued care in the community to prevent these adverse outcomes occurring. The Clinical Frailty Scale has good predictive accuracy in identifying frail older adults at increased risk of adverse outcomes and those likely to benefit from geriatric intervention. Frailty identification in the emergency department should be integrated into routine care to aid decision-making regarding interventions, discharge planning, and transfer of care to the community to improve patient outcomes and reduce the burden on the healthcare system. There is need for more randomized controlled trials looking at the effectiveness of screening tools in the emergency department against routine care, along with qualitative research on the perceptions and beliefs of patients and clinicians to help improve the integration of care between the acute and community setting. Here is the reference list, and thank you for listening.